Good afternoon, everyone, and welcome to the webinar, When to Refer to an Endocrinologist and Updates in Pharmaceutical Treatment. This webinar is brought to you by the Maryland Department of Health. My name is Sue Lockenmeyer. I'm your moderator today, and I'm with the Maryland Living Well Center of Excellence. Our speakers today are Dr. Sadie Peters, Dr. Eva Singh, Dr. Sudeepa Zakar, and Dr. Nancy Rodriguez-Weller, and me. So we've got an incredible lineup, really remarkable leaders in the field, and we'll have very important information for you. I do want to remind you, please submit your questions via the Q&A tab throughout the presentation. We will have time after the presentations. And we'll also be able to have you join at that time after the presentations. If you go to your participant name, raise your hand, and we will be able to unmute them. So as a reminder, we really want you to complete the post survey immediately after the webinar. This will be necessary if you're receiving CEUs, and we really value the information. It's tremendously important to us. So let me get started by introducing Dr. Sadie Peters, who is the Medical Director in the Center for Population Health Initiatives at the Maryland Department of Health. She spent 8 years in clinical work at Johns Hopkins Community Physicians before joining the public health sector. Dr. Peters is interested in innovative interventions that expand population-level preventive health and management of chronic diseases like diabetes and cardiovascular disease. So Dr. Peters, take it away.
Thank you, Sue, and good evening, everyone. I'm hoping that you all can hear me. Great, wonderful. A lot of the webinar's content tonight is intended, if we can go, yeah, we'll start there. A lot of the webinar's content tonight is really intended to help support the work that clinicians and clinical teams do in direct patient care and management. While caring for people with diabetes does really heavily depend on a coordinated team of nurses and primary care providers who are the primary treating clinicians, and pharmacists and medical assistants, care managers, and more, optimal diabetes care also really requires a systematic approach to comprehensive care quality and an awareness of how your care team is performing within your practice, within your health system, and even within your state. We have to be aware of the data that describes our patients, and in general, it's important to know that the data describing patients with diabetes across the country shows that there's a lot of room for improvement in the care provided. Next slide, please. The American Diabetes Association, in their Standards of Medical Care for Diabetes 2020, reported that between 2013 and 2016, 64% of the nation's adults with diabetes met their targets for hemoglobin A1C. 70% of adults with diabetes met their targets for blood pressure, 57% were at goal LDL, and 85% were not current smokers. Some of these numbers don't look so terrible, but we all know that to avoid or delay the cardiovascular disease that's so commonly the cause of death for people with diabetes, it's extremely important to meet targets for all these parameters. And I neglected to turn my camera on, but okay. The ADA reports that only 23% of patients actually do meet their targets for A1C, blood pressure, or lipids while also refraining from smoking. And that's a really low number. And we hope that you'll actively work with us in your own clinical setting as we work statewide towards system level and population level improvements in these statistics. Next slide, please. Here are some data that are more specific to Maryland. On the left, we have the deaths from diabetes in Maryland over the last 9 years for which we have full data. These data are from Maryland's vital statistics. You'll see here that in Maryland, deaths from diabetes are slightly lower than diabetes deaths in the United States, but the patterns are very similar. The tables on the right show that there has been slight fluctuation of the diabetes-related ED visits per 1,000 population between 2013 and 2017, and that's seen in the top table. But as seen in the bottom table, the diabetes hospital discharges, there we go. The diabetes hospital discharge rate has had a small, steady increase over those same years. In 2017, Maryland hospitals charged about $197 million for diabetes-related inpatient stays, and that's an increase of more than 30% since 2013. If we include pre-diabetes in the cost estimates, diabetes and pre-diabetes cost Maryland an estimated $7.01 billion annually. Clearly, the health system costs of taking care of people with diabetes or people who are at risk of diabetes are staggering. Next slide, please. In 2019, Maryland broadened its all-payer agreement with the federal government, more specifically with the Centers for Medicare and Medicaid Services, CMS, and initiated the Maryland Total Cost of Care model. The Total Cost of Care model places emphasis on providing patient-centered care with new and innovative practices and policies that are aimed at improving overall care quality, improving population health, and moderating the growth of hospital costs. This model aims to transform Maryland's healthcare system to be more reliable and more efficient by increasing collaboration among health systems, payers, community hospitals, ambulatory physician practices, long-term care, and other providers, as well as patients and their families, public health, and community-based organizations. The Maryland Primary Care Program is one of the program components of the model. To round out the agreement, Maryland also committed to implement a statewide integrated health improvement strategy with 3 domains that maximize the population health opportunities made possible by the model. This slide, borrowed from our kind colleagues at the Health Services Cost Review Commission, depicts those domains. The objective of the total population health piece, which is the piece that's in the third circle number 3 in this Venn diagram, is to identify population health focus areas that the state can work on as part of the total cost of care model. Within this piece, there are so far 2 priority areas, diabetes and opioid use disorder. A work group has been meeting to arrive at specific diabetes-related goals and targets and measures that will then become a formal part of the model under this statewide integrated health improvement strategy. Next slide, please. So one of the requirements of the statewide integrated health improvement strategy is that the work must promote public and private partnerships with shared resources and infrastructure. Acknowledging that we could and should help lead the efforts to align existing resources, last year the Maryland Department of Health, in collaboration with many partners, introduced the Maryland Diabetes Action Plan. The plan relies on everyone's involvement and has strategies and action steps for healthcare providers and health systems, but also for community groups, employers and insurers, and state and local government. The plan has lots of action steps for diabetes management, but also has lots of action steps that go much further upstream to help keep people at a healthy weight, with suggestions for environmental and policy activities for each set of partners, and action steps to address overweight and obesity, as well as action steps to address prediabetes. It's just another aspect of the state's work to improve diabetes outcomes for the entire population. Next slide. There are other efforts to address diabetes management and prevention at the population level. Over the next 5 years, the Health Services Cost Review Commission's regional partnership grants will fund hospitals and their partners to implement or expand investments in diabetes prevention programs and diabetes self-management training programs, or to work on behavioral health crisis services, all in support of the population health goals of the total cost of care model. And yet another effort, local health improvement coalitions around the state are encouraged to focus on improving diabetes care in their jurisdictions, and they will be supported with funding from the Community Health Resources Commission, with technical assistance from one of the University of Maryland School of Public Health programs to improve their operations so that the LHICs can effectively work with their local partners to move that needle on diabetes care and outcomes. Today's educational webinar is part of a series of 8 delivered to clinicians and with a different set of content, a different content slant to patients and families with diabetes or who are at risk for diabetes. Also part of the series are 2 webinars targeting direct care community providers, namely community health workers. We are hoping that you who are on the webinar today will help spread the word among colleagues that even if they didn't join us today, these webinars are recorded and they can be watched anytime, and they come with CMEs. We saw that on the first slide of my presentation here, only 23% of people with diabetes met targets for A1C and blood pressure and cholesterol and have a non-smoking status. We don't have data specific for Maryland on these parameters, but we assume that our numbers are similar. As diabetes is a priority for our state, we are working to establish a diabetes clinical quality task force to identify ways in which we can do better with diabetes clinical management, prevention, and surveillance. So one of the key messages today is that your work in providing high quality care to people with diabetes is truly critical to meeting the state's population health goals. The webinar's later presentations about when and how to refer to specialists and to community programs that can be of help in the comprehensive patient-centered care that you provide for your patients will hopefully help you with some ideas and strategies to help overcome some of the challenging aspects of the work. Thank you so much for all you do. Sue, back to you.
Dr. Peters, thank you so much. What really important information. And I hope that all of you who are with us today will absolutely outreach to the other recorded webinars and share them with your staff, your team, and certainly with your patients as well. It is my pleasure now to introduce Dr. Eva Singh. She is a general internist and assistant professor in the Division of General Medicine at Johns Hopkins School of Medicine. Her research is focused on improving the health of patients with diabetes, obesity, and related conditions. And she's actually conducting intervention studies to improve the prevention of diabetes in primary care. Dr. Singh, thank you for joining us. Please unmute your line.
Great, thank you so much. So in this brief talk today, I will focus on discussing diabetes prevention and setting goals for lifestyle management of prediabetes and diabetes with your patients. I'm going to need your assistance in advancing the slides. So I have no financial disclosures. Next slide. So I would like to highlight that there is an abridged version of the American Diabetes Association Standards of Care, Medical Care in Diabetes that primary care providers can access and is a great resource. Next slide, please. So to start off, I would like to ask what people think are high-risk ethnic groups for prediabetes and diabetes. They include African American, Latino, Native American, Asian American, or Pacific Islander. So the answer is that all of these are high-risk ethnic groups. Next slide, please. So I would like to highlight the criteria for prediabetes and diabetes screening. Often we think about BMI, but we sometimes forget some of the other risk factors, which can include first degree relative with diabetes, the high-risk ethnic groups as mentioned in the previous slide, history of cardiovascular disease or hypertension, low HDL or high triglycerides, women with PCOS, and physical inactivity. Women with a history of gestational diabetes should begin lifelong testing and at least every 3 years. And for all others, testing should begin at age 45. And the recommendation is to test at least every 3 years if normal previously. Next slide, please. So the next question is, you have a patient with prediabetes who's overweight and obese. What is the recommended initial weight loss for your patient? 5 to 7%, 10%, or 15%? And the answer is 5 to 7% of body weight. And the reason I highlight this, this is from the diabetes prevention studies and is a goal that most patients can reasonably achieve. Next slide, please. So the recommendations for diabetes prevention come from the Diabetes Prevention Program studies, as well as several other landmark studies. And the DPP was a study that randomized patients to placebo versus intensive lifestyle intervention versus metformin. And at 22-year follow-up, the results showed a 25% risk reduction of diabetes with the intensive lifestyle intervention versus 18% with metformin compared to placebo. So based on these studies and other study findings, the recommendations are to refer patients with prediabetes to an intensive behavioral program model in the DPP, and that metformin can be considered in those with a BMI greater than or equal to 35, age less than 60, or prior history of gestational diabetes. And it is recommended that everyone receive annual testing to monitor for progression to diabetes. Next slide, please. Now, the National Diabetes Prevention Program is a CDC-recognized structured lifestyle change program that targets 5 to 7% weight loss and 150 minutes per week of physical activity. To be eligible, patients need to be age 18 older, be overweight or obese, and have labs consistent with prediabetes or prior gestational diabetes, or high risk based on the prediabetes risk test. These programs are conducted in person or online, and they last 1 year in duration. They're weekly for 6 months, then 1 to 2 times a month for 6 months. Insurance coverage includes Medicare and Medicaid in Maryland, as well as some private insurers. So it is a 1 year duration program, so it is a long-term commitment, and hence why it's called an intensive behavioral lifestyle program. Next slide, please. I would like to highlight an important resource for providers. The PreventDiabetesStat.org website is a collaboration between the CDC and AMA. And on there, they have a toolkit for healthcare providers, which includes a prediabetes risk score test. It includes patient handouts about prediabetes and the diabetes prevention programs, as well as patient letters and referral forms. Next slide, please. Now, in terms of the referral process for DPPs, patients can self-refer or be referred by their provider. There are sample referral forms available on that Prevent Diabetes Stat website I just mentioned. And you can find available listings of DPPs on the Maryland Department of Health website at this link below. Next slide, please. And when you hit that link, it brings you to this page here, in which you can enter your patient's zip code, and select Diabetes Prevention Program and hit Find Fax Number, and would bring up the closest program nearest to your patient. One caveat is that this does not necessarily mean that the program is currently enrolling. Also, there isn't currently a great mechanism for two-way communication between providers and DPPs, although some programs do utilize a particular software that generates reports that can be mailed, faxed, or emailed to the primary care provider, and provides updates on their patients' enrollment, participation, and progress. Next slide, please. So I know there'll be a subsequent talk on pharmacologic treatment, so I want to focus on setting goals with your patients for the lifestyle management of prediabetes and diabetes. Next slide, please. So in setting goals for your patients, which of the following is the best advice you can provide your patient on their after visit summary or instructions? Follow up in the office in 3 months so that we can discuss your progress with weight loss. Watch your diet closely to control your diabetes. Or we discuss your physical activity goal, 20 minutes of brisk walking 5 days a week. And the answer is that the third advice there is a goal that's specific, measurable, achievable, and realistic. Next slide, please. So I would like to highlight that in the decision cycle for the patient-centered glycemic management and type 2 diabetes, one area focuses on setting SMART goals. Slide, please. Next slide, please. And SMART goals stand for specific, so one clear action that you want your patient to achieve. Measurable, determining how you will quantify their progress so they can track it. Achievable, setting a goal that will challenge your patient but isn't impossible to achieve. Realistic, meaning you can determine that your patient can commit to and make sure it is within reach. And timely, defining the time frame for the goal. Next slide. So here are some examples of how to set SMART goals with your patients. So instead of saying a healthy diet is important, you might consider saying one of the dietary changes that we discussed is cutting down on eating fast food and bringing your lunch to work every day. Or instead of exercise will help you improve your diabetes, perhaps you might say we set a goal for you to start walking 15 minutes each day, at least 3 days a week. And in terms of talking about medications, you might say your A1C was 7.3%. We discussed setting a timer for the PM dose of your metformin, and this should help us to get your A1C goal of less than 7%. And finally, instead of saying weight loss is important for diabetes, you might want to reframe and say, we discussed that you will try to lose 5 pounds by your next appointment in 3 months. So after understanding how to set SMART goals with your patients, I wanted to discuss the lifestyle management of prediabetes and diabetes. So which of the following is the recommended eating pattern for diabetes? The dash, Mediterranean, vegetarian, low fat, or low carbohydrate? And the answer is that all of these may be considered, and that in fact, evidence does not show one dietary pattern to be more superior. Next slide. So the recommendations that I will present are from the 2019 Consensus Report on Nutrition Therapy for Adults with Diabetes or Prediabetes. Next slide. And in the consensus report, they recommend that all adults with type 1 or type 2 diabetes be referred to medical nutrition therapy at diagnosis and throughout their lifespan, and that people with prediabetes who are overweight or obese should be referred to intensive lifestyle intervention and or individualized medical nutrition therapy. Now, we know that medical nutrition therapy is a covered Medicare benefit. However, coverage of medical nutrition therapy for prediabetes does vary by insurance, but if your patient has other comorbidities, it may be covered. Next slide. So an eating pattern represents the totality of all foods and beverages consumed, and a variety of eating patterns are acceptable. Multiple trials and meta-analyses have compared specific eating patterns for diabetes, and no single pattern has emerged as being clearly superior to all others for all diabetes-related outcomes. So in general, whichever eating pattern your patient chooses, it should focus on non-starchy vegetables, minimizing added sugars and refined grains, whole foods over highly processed foods. In addition, it's been shown that reducing overall carb intake in diabetes has the strongest evidence for improving glycemia and may be applied to a variety of eating patterns. Next slide. And a note about glycemic index and load. We often talk to our patients about high and low glycemic index foods, and a systematic review of studies of glycemic index and glycemic load in people with diabetes or at risk of diabetes showed no significant impact on A1C and mixed results on fasting glucose. Next slide. So a variety of eating patterns have also been studied for preventing diabetes. So that includes Mediterranean style, vegetarian, low fat, and DASH eating patterns have all been shown to lower risk of developing diabetes and no effect for low carb eating patterns. However, these studies are limited, and so it's unclear as to which pattern is optimal. So many patients nowadays ask or follow intermittent fasting. Intermittent fasting is a way of eating that focuses more on when you eat, so consuming all daily calories in set hours during the day than what you eat. And while it usually involves set times for eating and set times for fasting, people can approach intermittent fasting in many ways. So in 3 of 4 studies in diabetes, they demonstrated that intermittent fasting may result in more weight loss, but no improvement in A1C compared to a non-fasting eating plan. In one study of prediabetes, they showed improved insulin sensitivity, but not weight loss. So overall, these results are mixed, and many do not control for intake amount, and the duration of these studies is short. We also don't know the long-term effects and whether it's safe in people on certain medications that are at risk for hypoglycemia. Next slide. So the takeaway points are that we should screen and test patients for prediabetes and diabetes regularly. We should refer patients with prediabetes to diabetes prevention programs, which are evidence-based and effective programs for reducing their risk of diabetes. We should set SMART goals with our patients. And finally, many eating patterns can be effective for preventing or managing diabetes, and no one is considered superior. Thank you.
Dr. Singh, thank you so much. That is really concrete, very specific information, a lot of it really cutting edge, and I think it's extraordinarily helpful to providers to really understand what the options are. So thank you for that. I'd like next to introduce Dr. Sudeepa Zakar. She is an assistant professor of medicine in the Division of Endocrinology, Diabetes, and Metabolism at Johns Hopkins University. Her clinical focus is on the treatment of patients with diabetes. Dr. Zakar, please take it away. Thank you.
Hi, everyone. Thanks for joining the meeting today. My name is Sudeepa Zakar. I'm an assistant professor of medicine in the Division of Endocrinology and Diabetes at Johns Hopkins. Next slide, please. So this is just a brief outline of my talk. I'll just address a few specific forms of diabetes, type 1 diabetes and monogenic diabetes. I'll also briefly discuss insulin pumps and smart pens, plus and minus continuous glucose monitoring systems. I'll briefly review the use of high doses of insulin, and then finally talk briefly about the use of GLP-1 receptor agonists and SGLT2 inhibitors in certain groups of people with diabetes. Next slide, please. So as we know, type 1 diabetes can occur really at any age, and it is characterized by autoimmune mediated destruction of the pancreatic beta cells, and it's usually characterized as people are characterized as having insulin deficiency, and if not at presentation, then within a few years of diagnosis. And the main thing to know for these patients is that they're at risk for diabetic ketoacidosis. And so in our clinic, for people with type 1 diabetes, we keep in mind that these patients should be screened for coexisting autoimmune diseases, and this can include thyroid disease and celiac disease. So as Dr. Peters and Dr. Singh also mentioned, the standards of medical care in diabetes. So these are the guidelines that are published by the American Diabetes Association once a year, and they're annotated online throughout the year as new evidence is published. So this is from the 2020 guidelines. And the ADA, the American Diabetes Association, notes that, if you could just go back, sorry. Yes, thank you. That for people with type 1 diabetes, these patients should be screened for autoimmune thyroid disease after diagnosis and periodically afterwards. And then also patients with type 1 diabetes should be screened for celiac disease in the presence of gastrointestinal symptoms, signs, or laboratory manifestations suggestive of celiac disease. And I've circled the B here just to, as a tangent to point out, next slide, please. That the ADA uses an evidence grading system of A, B, C, and E. And for B, they mean that supportive evidence from well-conducted cohort studies was used to make that recommendation. This is just a table from the New England Journal of Medicine that points out that type 1 diabetes can also be seen as part of a larger syndrome. These are called the polyglandular autoimmune syndromes. And type 1 diabetes can be, if you could go back to the previous slide, sorry. Thank you. Type 1 diabetes can be seen in the context of polyglandular autoimmune syndrome type 2. So that in this case, it's important that the patient is seen by an endocrinologist to screen and monitor for associated endocrinopathies that are seen with this polyglandular autoimmune syndrome type 2. Next slide, please. One aspect of diabetes is that technology is really rapidly advancing, and it changes, month to month. And so part of this includes continuous glucose monitoring devices. And these devices, of course, involve a small catheter that goes under the skin in the interstitial space and measures interstitial glucose. There is a lag time from blood glucose by about 15 minutes. And roughly these devices fall into two major categories. One is real-time continuous glucose monitoring that allows for continuous pickup of interstitial glucose data to a receiver. And the other is called the intermittent or flash continuous glucose monitoring system. And this differs from the real-time in that it requires that the patient periodically scan or use a flash device to pick up glucose data. And this can be done using a scanning device or using a patient's smartphone. So those are the two main categories of continuous glucose monitoring devices. And in people with type 1 diabetes, they have been shown to improve A1C and also reduce time spent in hypoglycemia. And similar evidence has been seen in people with type 2 diabetes. This is just a tracing from a real-time continuous glucose monitor. On the x-axis, we have a single day from 12 a.m. to 12 a.m. the next day. And then on the y-axis, you have the interstitial glucose levels. And then in the yellow and the red, so the yellow line represents the patient's upper limit of target glucose, and the red line is the lower limit of the patient's target glucose. And you can see that for this person, the tracing is pretty much between those two lines, which is good. And a few times the alarm for a high glucose went off, which real-time continuous glucose monitors allow for this alarm system. And recently, the intermittent glucose CGMs have also are able to also sound an alarm for high or low glucose. The nice thing about these CGMs is that they allow for data sharing. So this can be great for patients and providers, because as a provider, it allows me to review a patient's glucose data remotely, even if a patient's not in the office, if they allow permission for data sharing. So if a patient allows for permission to share data with the clinic and has any questions about glucose between visits, we can access a clinic portal and look at the patient's data, which can be very helpful. And this is possible with both the intermittent and the real-time continuous glucose monitoring systems. So these are just screenshots of the app or the software that's compatible with one of the intermittent CGM systems. Just a few words on insulin pumps. So these are used in people with type 1 diabetes, as well as patients with type 2 diabetes who require multiple daily injections of insulin. So these pumps are available both with and without tubing, depending on the type of pump. In general, pumps have a few basic parameters. So one is the basal rate. This allows for a provider to set the rate of insulin that a patient receives under the skin in units per hour. So this can be it can be programmed to change at various times within a single day. The second major part is the Bolus Calculator. So this allows providers to set an insulin to carbohydrate ratio, which is the amount of insulin that a patient is estimated to need for a given amount of carbohydrates. And this can also vary throughout the day. So for example, a patient can have insulin to carbohydrate ratio of 15 for breakfast and 10 for lunch and dinner. The insulin sensitivity factor is a measure of how much we estimate that a patient's blood glucose will decrease given a unit of insulin. So this can range from very sensitive, for example, if we think that a patient's glucose drops by 100 for 1 unit of insulin versus patients with more insulin resistance. For example, if they have an insulin sensitivity factor of 10, meaning blood glucose drops by 10 for every 1 unit of insulin. Pumps allow for us to set a target blood glucose, and this, of course, can depend on the patient and his or her comorbidities. And finally, there's something called active insulin time. So this is an estimate of how long we think the insulin is working in a patient's body. So this can vary. So in patients who might be more insulin sensitive, we may set the active time to be longer than in patients who are more insulin resistant. Next slide, please. So this is just a snapshot, actually an app, a simulator app that anyone can download onto a smartphone of an integrated hybrid closed loop system that allows for data acquisition by a pump using sensor data. So this patient has a sensor measuring interstitial glucose in real time, as well as a pump, and the pump is able to change insulin rates depending on the information that it's receiving from the sensor. So this is nice because a couple of things. One, the pump can predict low glucose and actually shut the pump off or turn the insulin off if it predicts glucose will drop within a certain amount of time. And also it can correct for higher glucoses, so the basal rate, that amount of insulin that a patient receives per hour, can be increased. And this is something that the pump is doing without direction from the patient or the provider. And this is just a different picture of the same idea, the hybrid closed loop system. So this gives you an idea of how the patient is doing using the sensor data. And in this system, the pump, again, is using the sensor data to make corrections in real time to the patient's insulin dosing. This is something called a smart insulin pen. This is the InPen. It's the only FDA-approved insulin pen on the market. And basically what the smart insulin pen does is that it administers insulin. So it administers only short-acting insulin, not long-acting insulin. But the reason it's different from a regular insulin pen is that it is able to sync with an app on a patient's smartphone and able to record the amount of insulin that a patient is receiving. Not only that, it can help calculate the amount of insulin that a patient needs using those parameters that we discussed earlier, meaning the insulin to carbohydrate ratio, the sensitivity factor, and the active insulin time. And then it also calculates something called insulin on board, meaning it gives the patient an idea of how much insulin might still be in their system, and that can help make decisions about how to dose insulin moving forward. For example, if a patient receives 6 units of short-acting insulin for lunch and decides to eat a snack about an hour later, we know that the patient will probably need less insulin because he or she took insulin an hour before. And so the smart insulin pen helps calculate that dose. I just wanted to touch a bit on diabetes syndromes, and in these patients who have these syndromes should probably be referred to an endocrinologist, and these include maturity onset diabetes of the young, or MODY, and neonatal diabetes. So neonatal diabetes, this can be caused by a single genetic mutation, and over 20 mutations have been identified to date. These patients are usually diagnosed before 6 months of age. And the treatment can be insulin or sulfonylureas, depending on the type of the diabetes. So that's where diagnosis is very important. This is just a schematic of who to test for a MODY. So it's a bit hard to read, but I'll read it out to you. So patients to consider testing for MODY are those people with a diagnosis of type 1 diabetes and one or more of the following, including negative pancreatic autoantibodies, evidence of endogenous insulin production beyond the so-called honeymoon period, so several years after diagnosis. And additionally, patients with type 2 diabetes with one of the following, so someone who has normal weight or has considered to be mildly overweight, with patients with no evidence of insulin resistance and no other signs of metabolic dysfunction. So these patients should probably be referred for testing for monogenic diabetes. This is also hard to read, I apologize, but basically this is just a short list of some of the genetic mutations that are part of the MODY spectrum. So again, these are monogenic, this is a monogenic diabetes syndrome, so each of these MODYs is caused by a single gene defect. And what you can see here is that the treatment actually depends on the type of MODY that's diagnosed. So some of these patients can be treated with insulin, whereas others can be treated with sulfonylureas. So treatment really varies widely depending on the type of MODY that the patient has. I just wanted to share a case with you all. So this is a patient who's 54 years old. She has a history of type 2 diabetes on insulin, and she presents to clinic for a routine visit to follow up of diabetes. She takes insulin glargine U100 80 units twice a day, and insulin lispro U100 40 units 3 times daily with meals. So five injections a day. Her point of care A1C in clinic is 10%, and her A1C 3 months prior was 9.5. She was unable to bring her meter to the visit, and then she reports that she is adherent to the medication. She is taking the 5 injections a day. She does have a history of intolerance to metformin. And then one important thing to note is that she does have a history of pancreatitis, unclear etiology, and then also a history of multiple genital yeast infections. So which of the following treatment options should be considered? Again, there's no absolute right answer, but the options are A, switching from insulin glargine U100 to U300, 80 units twice a day, canagliflozin 100 once a day, semaglutide 0.25 weekly subcutaneously, or metformin 500 milligrams twice a day. So in my opinion, I think the answer is probably A at this point. And the reasons I wouldn't consider the other medications, or I probably wouldn't move towards the other medications, is that, given her history of multiple yeast infections, canagliflozin may not be the optimal next choice. She does have a history of pancreatitis, so starting semaglutide might be less reasonable. And then she has a recorded history of intolerance to metformin. So I think in this patient's case, where she's on more than 200 units of insulin a day, she may benefit from switching to more concentrated insulin. Next slide, please. So I'll just quickly review this. There are several concentrated insulins on the market. There's regular insulin, which is U500 or 500 units of insulin per ml. Lispro insulin comes in a concentrated form of U200. Glargine comes in a form of U300, meaning 300 units per ml. And insulin degludec, there's a U200 form, meaning 200 units per ml. And the benefits of these concentrated insulins is that they allow for administration of insulin in a smaller volume. So you can have a person who's on a high amount of insulin, but is able to receive the insulin in a smaller volume. And then just a note on U500 insulin, it was initially developed for use in people who were requiring more than 200 units of insulin a day, and it does act as both a basal and a bolus insulin. So that's important for patients to know, that it's not just insulin to take with meals, but that it acts as both basal and both bolus insulin. So that's important, because if a patient is not eating, it may not mean that he or she can just completely stop the U500 insulin. And one other important thing to know is that the greater the concentration of insulin, it's associated with a slower rate of absorption. And then just a few words on the GLP-1 receptor agonists and SGLT2 inhibitors. GLP-1 receptor agonists are not approved in people with type 1 diabetes. They have been used in people with type 1 diabetes off-label to help improve weight gain, but they're not actually approved for use. And the other thing is that SGLT2 inhibitors, I didn't put the patient population, but probably should be avoided in people with type 1 diabetes because of their association with diabetic ketoacidosis in people with predisposing factors. So those include people with type 1 diabetes, people with ketosis-prone diabetes, and could potentially include those patients who have had diabetes for many years, have been on insulin for many years, who may actually just have very, very little endogenous insulin production. Those patients, you know, I would generally maybe refer to an endocrinologist before deciding to use an SGLT2 inhibitor. Any questions? Thank you very much.
Oh, Dr. Zakar, thank you so much. You know, we have been hearing over these webinars how complicated diabetes is, and your presentation and Dr. Singh certainly make us very much aware of how complicated it is and why an endocrinologist really may be an important component. I do want to remind everybody to ask questions in the chat, or in the Q&A, please. And then I would like to transition to introduce Dr. Nancy Rodriguez-Weller. She's on faculty at the University of Maryland Eastern Shore Pharmacy Practice and Administration School of Pharmacy and Health Professions. She is an advanced pharmacy practice experience preceptor in geriatrics and has worked extensively on medication use in the elderly and on the burden of dementia and depression in older adults. And we certainly know there is a tremendous link between depression and diabetes as well. So Dr. Rodriguez-Weller, please take it away. Thank you.
Okay, thank you. Can you hear me?
Yes.
Okay, thank you. Okay, so thank you for allowing me to participate in this discussion and webinar. I do not have any financial disclosures to announce. Next slide, please. So I'd like to begin by saying that this is a very difficult subject, the pharmacy section, to cover over a 15-minute period, but I'm going to try my best to cover it quickly, discussing some basic treatment considerations and treatment goals. I've also included an overview of the available oral versus insulin products, and then I would like to discuss and introduce you to some newer products that have been discussed and coming up in the research world and diabetic treatment. Next slide, please. So when we treat diabetes, patients need to be assessed thoroughly. We need to consider not only the medical aspect, but the psychological and functional ability of the individual. Some things to think about. Is the patient able to self-manage? Is polypharmacy present? Is the patient cognitively impaired? Are they depressed? Are falls occurring? And does the patient complain of urinary incontinence or pain? Do they have social issues that need to be addressed? Next slide, please. So the American Diabetic Association and the American Association of Clinical Endocrinologists recommend A1C, fasting plasma glucose, and postprandial glucose targets to monitor. These recommendations are based on findings from 4 major clinical trials in type 2 diabetes and 1 trial in type 1 diabetes. Now, these targets are based on life expectancy, the duration of diabetes, the presence or absence of microvascular and macrovascular complications, and comorbid conditions that include cardiovascular disease risk factors, and the risk for developing or consequences of severe hypoglycemia. And we need to also consider, again, the patient's social, psychological, and economic status. Next slide, please. So the management goals in older adults is a little bit different than the goals recommended for younger individuals. Older adults have higher rates of premature death. They may have disabilities, muscle loss, and diseases such as hypertension, coronary artery disease, and stroke. So target approaches are slightly different than in people diagnosed with diabetes who are younger than 65 years old. The goals will vary depending on whether an individual is fairly healthy, whether they have a complex medical history, or if they are in poor health with a limited life expectancy. But the one thing I do want to point out is that it is very important to maintain blood pressure and cholesterol health in all scenarios. Next slide, please. So as clinicians, the patient-centered approach in determining appropriate drug therapy should be considered. Does the individual have a history of cardiovascular issues? Are they diabetically stable? Are they experiencing bouts of hypoglycemia? Are they overweight? Are they concerned with cost? And are they experiencing side effects? And most importantly, what does the patient prefer to use? Next slide, please. So I want to piggyback on what Dr. Zakar mentioned about the management of diabetes with insulin, and specifically with the use of pumps. So we know that insulin is used exclusively in type 1 diabetes and can be used alone. In type 2 diabetes, insulin is used alone or along with other anti-diabetic agents. The insulin pumps are now much more popular. We know that the basal rapid-acting injections allow for tighter control and more flexibility with meals. And these gadgets help in making sure patients are compliant. They do vary in cost. They can be linked to phone apps. They're even available as waterproof for patients who are active and are swimmers or are exercise buffs. And ultimately, these types of gadgets improve compliance since they offer less shots than the multiple daily injections, making it much more comfortable for patients who can use these. The only thing that's a deterrent is, of course, cost, but in some cases, they can be managed through insurance companies and the companies that make these apparatuses. Next slide, please. Now, there are many insulin options varying on type, peak, and duration of action. These are available not only in vials, but now in the form of pens. And again, to piggyback on what Dr. Zakar pointed out, there are smart insulin pens that are available as well. These insulin pen devices have several advantages over the traditional vial and syringe method of insulin delivery. They do improve patient satisfaction and adherence. They are much easier to use. They have a superior accuracy for delivering small doses of insulin. Patients are happier using them because they provide some social acceptability. And patients report less injection pain. Now, although insulin pens provide many benefits, they do have some drawbacks that as a clinician you need to be aware. And that's that there is a restriction on using all types of insulin through a pen. For example, using mixtures of different types in one injection. A higher cost is involved. If you compare the pen to the vial and syringe method, the insulin pens are about 30% more expensive. The barriers to insulin use do include the fear of injections, the belief that insulin use is complicated, and some patients may fear that they are losing independence or a change in lifestyle. So there is some stigma attached to needle use. Next slide, please. So when we talk about the management of diabetes type 2, there are many options, and these classes of drugs are distinguished by their mechanisms of action. And in some cases, if glucose control is not achieved with a single medication, it's not unusual to add another medication to treat diabetes for a different class. Insulin can be added to the treatment plan if after 2 to 3 oral medications are added, glucose control is not achieved. Next slide, please. So the medications used to treat diabetes differ in mechanisms of action, efficacy, the effects on weight, and there are some dosing and renal considerations, as well as there are products that offer arteriosclerotic or cardiovascular or heart failure benefits. And when we think about this, this is something else to consider, is that some of these products are more expensive than others. Next slide, please. So this detailed schematic offers guidance in providing efficacious treatment in patients who have cardiovascular disease, heart failure, and chronic kidney disease. There's also consideration about who are at risk for hypoglycemia or in need of weight loss. This diagram offers guidance for patients who have certain disease states and which products are recommended to be used in the presence of these conditions. It's recommended, as one of the physicians pointed out, I believe is Dr. Singh, that it's recommended to reevaluate patients every 3 to 4 months, changing therapy as a per patient-centered approach. Next slide, please. So when do we want to start insulin, particularly in a patient who has type 2 diabetes? Patients need to be started when they have hyperglycemic emergencies, when their hyperglycemia occurs or is and the patient has a markedly high A1C. Insulin should be started in severe hepatic and renal disease and in patients who have coronary artery disease and very elevated triglyceride levels. It should also be considered when patients have been tried on oral and injectable agents and do not get a response from these. Patients may also experience unacceptable side effects of any of these oral and injectable agents, and so insulin needs to be considered. Another factor in starting insulin is when a patient wants more flexibility. Insulin should also be used in patients who have some special circumstances where they're using long-term steroids or have infections or are pregnant. Next slide, please. Now let's talk about some newer drug treatments. There are a lot of combination medications that are available now, and they're used to increase compliance. One thing that I do need to point out is that if they are prescribed, insurance companies may or may not approve. So that is a big factor in the determination of using these brand new combination medications. The ones that are highlighted in red are the ones that I'm going to just briefly discuss. Ziltafy, which was approved in 2016, can only be used to treat type 2 diabetes. It combines insulin diclofenac, a long-acting insulin, with liraglutide, a GLP-2 antagonist. It's usually injected once daily. And then we have Victosa. Victosa has been around for a little bit, but it is the first non-insulin drug approved to treat diabetes in pediatric patients. It's now approved for pediatric patients 10 years and older for the treatment of type 2 diabetes. The next drug I'd like to point out is Ribelsis, which is a semaglutide approved in September 2019. It is not recommended as a first-line therapy. The starting dose is 3 milligrams PO daily for 30 days, and then it can be increased to 7 milligrams PO once daily if necessary. And if glucose control is not achieved, it can be further increased to 14 milligrams daily. The next drug that I'd like to point out is Baxiemi, which is a nasal powder, the first glucagon therapy that can be used for emergency treatment for severe hypoglycemia. This is pretty interesting in that if we were to use glucagon injection, you have to mix it. Baxiemi is a product that is approved for patients 4 years old and older, and is ready to use in a pre-measured dose. Next slide, please. Now, there are some diabetic pipeline drugs that are being researched now. The first one, imaglimin, improves glucose hemostasis. It's in phase 3. Next slide, please. It has 5 different mechanisms of action, which makes it a little bit more interesting in managing or improving glucose homeostasis. Can we go back to the prior slide? Okay, thank you. The next item I'd like to point out is the Desa Glucon Hypopal Rescue Pen, which is an analog of human glucagon. It is a ready-to-use pen, can be offered to diabetic patients for the treatment of severe hypoglycemia. This particular drug is in phase 3 trials in adults and pediatrics. The company remains on track for the potential launch of this particular rescue pen by the year 2021. The next product is the Trulicity. This particular drug has been in the market, but now it extended the label to include a 3.0 milligram and 4.5 milligram dose based on data that was retrieved from an Award 11 study. The next medication is tirzepatide, which is a dual GIP and GLP-1 receptor agonist. It is available to be used sub-Q. And the next product I'd like to discuss is the oral Lin, which is an inhaled human insulin. It is presently approved in other countries, but is being studied in North America right now for further approval. The next item is a human insulin, which is available as an inhaled product. It's a soft mist inhaled human insulin to be used for the type 1 and type 2 diabetes. It is based on 5 phase 1 and 2 studies. So this sounds a little promising. The last product, which is the AER601, is another inhaled short-acting glucagon-like peptide or GLP-1 analog, also right now in phase 1 studies. Next slide, please, and next slide. So that concludes my presentation. I will take questions at the end, and again, I give it back to Sue. Thank you.
Oh, thank you very much. Truthfully, I'm overwhelmed by the complicity, how complex issues around diabetes. I know that this is tremendously important to providers in the field. So thank you Dr. Rodriguez-Weller as well. Really incredible information. So we're going to go quickly. This is oh, great. So references are here. I do want to point out two things. One, don't forget to put questions in the chat. And all of our webinars will be available as recordings, and as Dr. Peters indicated early in this presentation, you are able to get CMEs as well with them. So important for you if you need to. We're good. That's great. So this is pretty rudimentary compared to the high level information you've gotten so far. And so it's just really a quick reminder about the evidence-based programs. Dr. Singh really spoke about them as important programs and the things that we can do in community to support your partnership with your clients and patients in terms of managing diabetes. So next slide. So again, evidence-based behavior change programs, they work because from the studies, people who have diabetes or prediabetes have similar concerns and problems, and they have to deal most importantly, not only with their disease, can you go back please? Not only with their disease, management skills. So next slide. So it seems, have we lost the slides, or am I off? Let's see, there we go. Okay. All right, so again, essentially the goals of these self-management programs are to encourage and empower people to take responsibility to manage or co-manage their diabetes, to be active participants, and I especially appreciated the SMART goals that Dr. Singh provided in her remarks in terms of becoming really part of the team. And then most importantly, to gain confidence to be able to perform tasks and focus on improving health, and including accessing whatever the healthcare services are. And then next slide. So this is really the key components in the diabetes self-management program. These can be done with reimbursement under AADE as well. And we have several folks in the state who are doing this. So the key self-management strategies are decision-making, problem-solving, action planning, and including physical activity regularly. There's topics on diabetes, what it is, on how to monitor, healthy eating plan, how to prevent low blood sugar and what you do in that case, preventing or delaying any complications, and then planning strategies for sick days and foot care. So again, important up-to-date information to help individuals when they are not in their provider's office. Next slide. So again, programs are open to individuals 18 and older and to caregivers. They're generally 6 weeks, 2.5 hours a session. Again, we're doing programs virtually now, so they can be either virtual or in person, depending on where you are. The two trainers are generally non-health professionals, or if they're healthcare professionals, they're not wearing that hat because it is considered a peer-led program. So people
Thank you for
they're generally free in the state of Maryland. And again, it's for participants to become very active in their own care, and it does not replace existing programs or treatments. So next slide. Again, I know Dr. Singh indicated the Be Healthy site and our Maryland Living Well site, places where you can register somebody for an evidence-based program. And we also train people to become leaders and counselors. So again, we have that as a contact as well. And next slide. So I just wanted to provide briefly some additional resources that you and your office may not be aware of. I work for an area agency on aging, and we have one in every county in Maryland. We also have them in every county across the United States. But they do provide nutritional counseling and education and care planning and meals, financial assistance for individuals, low-income individuals who need assistance. There is some in-home care that can be provided, and as well there are assisted living subsidies and telephone reassurance, options counseling, other ways to reach out and connect your patients when you may not be seeing them. And then there's also often assistance for dental care, eye care, and hearing aids. Right now, our senior centers are not open, but they really provide opportunities for exercise and socialization, and certainly support groups are important and are available. And then lifelong learning and then people may need either transportation or assistive technology, ramps in their homes, bars in the bathroom, things like that are also available through AAAs. And then those health and wellness programs that were highlighted on the first slide, and we've been talking about the diabetes program. Next slide. So other services, again, the AAA focused on elder abuse prevention and financial exploitation, durable equipment reuse program that I already mentioned, the senior call check, also the senior Medicare patrol and state health insurance program. Again, we talked about Meals on Wheels and other programs there. Communities for Life, which is for more medium income people, but certainly they have issues as well. And then congregate housing, senior housing, again, ombudsman services for residents in assisted living and nursing homes, and public guardianship, senior legal assistance. So again, all of these are resources that as you deal with your patients, particularly now in COVID, some of these other services may be needed, and they are available near you. Next slide. And then just briefly, some of the programs from Dr. Peters mentioned LHICS. And so the local health departments and those services, smoking cessation, substance abuse prevention, again, the diabetes prevention program, dental services, other community health services, transportation, access to care, behavioral health, lots of healthy weight initiatives across the state, medical assistance, and then the adult evaluation and review services AIRS, which is around older adults and a criteria for Medicaid. So I think that's the end of my slides, if I recall, just double check. Yes, good. So I would like to open it up both to our attendees. If you have questions, again, go in by your name and you can raise your hand. And I would like for you, please, if you would, our speakers, if you would put your videos and your mics on, and certainly as we're looking and awaiting some questions, you may have some questions of each other or some observations that you'd like to share. Dr. Zakar, and is Dr. Peters still with us?
I am.
Okay, good, good. Just double checking. In terms of other questions, other thoughts, a really powerful group of presentations, again, highly complex in terms of the real management, effective management of diabetes.
Well, I'm wondering if Ann Langley, who is the director for our Center for Population Health Initiatives at the Maryland Department of Health, would like to highlight anything.
That would be great. And can you put your mic on and your video?
Okay, I got both at once. Um, I would just, well, first of all, I'd really like to thank the panelists. This was a great way to we're at the 7 out of 8 webinars. This is sort of a great culmination, I think. I hope that those of you who have been with us today will complete the post webinar survey. This is really the first big activity produced by the Center for Population Health Initiatives, which was started in February. And it's really just a toe in the water. It's been a great experience to put these together, but over the next 5 years, we're going to be working really across all sectors at improving diabetes care and supporting efforts, supporting the diabetes prevention programs and other efforts to prevent diabetes, and working all the way upstream to reducing BMI, addressing the overweight and obese population, all the way up until we have a big advocate on our staff for not forgetting to work with the group of people who are at a healthy weight and how to maintain that and how to grow that population for our state. So any input that any participants have today about what you'd like to see, what would be most helpful to you as clinicians, but also what would be helpful to your patients. We want to, as we develop these programs, we want to branch out and do some different kinds of things and do things that you think would be of the greatest benefit. We'll also be, I really especially like doing these kinds of things where we are reaching individuals and having an opportunity to exchange one-on-one, but of course, to really move the needle in diabetes in the state, we're going to have to be looking at much bigger scale interventions as well, some structural and policy changes. And so I just started with the department in February, and it's been a great 7 months. Dr. Peters has been a huge help. She's been with the department for a while and has helped me get up to speed. And so we look forward to working with all of you and appreciate your input.
Thank you very much, Anne. And I really hope the folks who have attended today will consider sharing information about this webinar. Again, the recording should be available in a couple of days, as will all of the recordings. And you can go, I know what's planned is that really anyone who registered or attended any of the sessions will sort of get an outreach when we have all of the recordings, to just remind you that these are things you could show. You could certainly download the ones that are for patients and be able to show them or to let people know about them. So again, we really want to be able to reach as many people as we can. The good news is we have our last
Sue keeps freezing up.
Yeah, Sue, I think you're frozen right now.
All right, so let me see if does it help if I turn off my, can you hear me now?
We can
Yes,
hear
that
you.
helps. I think
It's
that
just,
helps.
it's just too much of me, that's all. But what I was saying is that we are going to be sending out to everyone who attended or registered, intending to attend, information about all of the webinar recordings. And I hope that you will use them and share those links with patients, with clients, with colleagues, because the information is incredibly valuable and has been really current. And we really have valued the expertise of our presenters across all of these programs. Anybody else?
I just wanted to thank you for the opportunity because this is an important subject. So thank you.
Oh, Dr. Rodriguez-Weller, thank you so much. Actually, Dr. Nancy does our falls prevention programs as well with seniors. So again, providing important information on medications and risks. So we're really so thrilled to have you, and we've had such remarkable presenters. And so we're just really grateful for that, and really highlighting, you know, very current information and what's happening in the field. So much appreciated. Anybody else? I don't think we could ever get anybody to want to speak with us tonight. Maybe we have just completely filled their minds with a lot of good information. I hope that's the case. Unless anyone has, go ahead, Ann.
The patient webinars were more fun. We even had a couple of people share some of their personal experiences, which was, and actually that's an area that I'd like to explore some more as we
absolutely
develop programming.
Yeah, and Dr. Zakar, I just wonder if you had any final words. Again, tremendously important information that you shared.
Thank you, Sue, for the invitation. I think, if anything, I would encourage primary care providers to refer patients to us, even if it's just a one-time consultation or a patient that we manage for a certain duration of time and then transfer care back to primary care providers. But we're always here to help.
Wonderful, wonderful, great work, and we really appreciate you. Well, thank you all. Remember to fill out the post survey and the evaluation. As Ann indicated, it's so important to us to learn what else you need. And again, you'll be hearing from us. Thank you all very much, and good night.